What's up, Ninja Nerds? In this video today, we're going to be talking about chronic kidney disease, also known as CKD. Before we get started, if you guys want to follow along with some awesome notes, illustrations, go down in the description box below. We'll have a link to our website. Go check that out. Also, if you like these videos, it helps, it benefits, please support us by hitting that like button, commenting down in the comment section, but most importantly, subscribe. All right, Ninja Nerds, let's get into it. All right, Ninja Nerds, let's talk about chronic kidney disease. How do we first off just define what is chronic kidney disease? Well, first off, before we can define that, you have to know kind of the basic idea of what the kidneys do. Because a chronic kidney disease is the kidney's inability to perform those functions after a certain period of time of, continuous injury to the kidneys. And we'll talk about what are those things that cause this kidney injury, but what is kind of the basic functions of the kidney? Well, one of the big ones is, it removes waste, right? So waste removal. And sometimes that's in the form of drugs, that's in the form of urea, that's in the form of creatinine, things of that nature. It also regulates our water balance, right? So it's important for being able to regulate our water balance, making sure that we have enough of the water within our plasma and we're not actually eliminating too much of it in our actual urine. It also maintains electrolytes, electrolyte balance, particularly things like potassium and phosphate and calcium and sodium, right? It also maintains our acid-base balance. And it may even have particular hormones that we release, things like erythropoietin. It has enzymes that are involved within vitamin D activation, which control PTH levels, so on and so forth. What happens is when someone develops a chronic kidney disease, and when I say chronic, because you can have something called an acute kidney injury, and then you can have something called chronic kidney disease. Well, chronic kidney disease is when a lot of these functions, so you have a decrease in renal function. And this is usually for greater than or equal to 3 months. This is how we kind of define our CKD, okay, chronic kidney disease, is a decline in renal function, usually a lot of these particular things over 3+ months. Now, when we really kind of look at renal function, one of the most common ways by which we actually determine renal function is a lot kind of related to this, but it's particularly related to how often the actual filtrate is moving out of the glomerulus and into the actual tubules. And what is that called? It's called the glomerular filtration rate. So generally, one of the biggest things that we utilize is actually what's called GFR, glomerular filtration rate. And usually what happens is the renal function, the ability to filter make urine, filter things out of the actual glomerulus and into the tubules, starts to decline. And once that starts kind of dropping less than 90, we start seeing signs of some chronic kidney disease. Okay? All right, beautiful. Now the next question I have for you guys is what can actually cause chronic kidney disease? What are the underlying causes? Well, the big ones that I want you guys to remember, the first one here is hypertension. Hypertension is a very common cause. It's actually like one of the second most common causes behind someone developing chronic kidney disease. Now, how does this actually happen? When you have high blood pressure, right? So high blood pressure, a lot of that blood pressure is going to exert its way, right? So when you have a high blood pressure, you may have a high blood pressure moving into what's called the glomeruli via the afferent arteriole. Now, when there's a lot of pressure moving through the glomerulus, that may lead to kind of a hyperfiltration response. And then you'll have blood that exits out of the glomerulus via the efferent arteriole. Well, you know what happens with this consistently high blood pressure? It starts to cause thickening. Let's actually represent this here. No, we'll just do this. We have some thickening of the walls of the vessel. So you're going to start getting some thickening of the actual walls of the vessel. Now, you know how this happens? It causes thickening by leading to lots of protein deposition. And you know what they call this whenever you have high blood pressure? It leads to thickening of the vessel walls. It leads to what's called hyaline arteriosclerosis, which is like this thickening of the vessel walls. Now, imagine here for a second. If you have a thickening of the vessel walls, right? What's going to happen to the ability, whenever these vessel walls thicken, things like oxygen has to be able to move from the blood and into the actual tissues around the actual glomerulus to supply particular things of like the mesangial cells, like the different parts of the tubular cells. And if there is a decreased exchange due to the thickening of the vessel wall, what happens? Well, this hyaline arteriosclerosis, which leads to thickening of the vessel wall, leads to less oxygen delivery. And this leads to less oxygen delivery to parts of what? You know, there's some cells here. There's some purplish cells that sit in here. These are called your mesangial cells. The mesangial cells are kind of like these supportive cells around the glomerulus, okay? They get less oxygen delivery. And these cells, the tubular cells that are involved in reabsorption and secretion, they get less oxygen. As there's less oxygen delivery, the cells start to undergo ischemia and maybe even undergo necrosis. Now, what our body tries to do is, it tells these mesangial cells, they're very sensitive to low oxygen. And they say, hey man, I'm not getting as much oxygen as I want. I don't like that. And these mesangial cells start secreting some chemicals that are more protective in nature. They're trying to be protective. It's called transforming growth factor beta. What is it called? Transforming growth factor beta. Now, you know what transforming growth factor beta does? It activates particular fibroblasts in the nearby vicinity, and it starts causing fibrous tissue deposition. A lot of extracellular matrix that's actually going to be deposited into this area, around the vessels, around the glomerulus. So now I'm going to have tons and tons of fibrosis. You know what this is? What happens with this? So we have ischemia and necrosis. This stimulates your mesangial cells. The mesangial cells become activated and they start to secrete transforming growth factor beta, and that leads to fibrosis. But you know, we give this a very particular name. We call this, whenever it's causing fibrosis around the glomerulus, we call this glomerulosclerosis. Now it's super fibrotic. And because it becomes super fibrotic and thickened all around this actual glomerulus, guess what's going to happen? It's going to be even harder. If it's super thickened around this glomerulus and nearby structures, what do you think is going to happen to the ability to filter things across the glomerulus and into this kidney tubules? It's going to decline like a son of a gun. So as a result of this glomerulosclerosis, they may result in a decreased GFR. And a decreased GFR for at least 3+ months can lead to signs or evidence of chronic kidney disease. And so this may lead to a decrease in the glomerular filtration rate. Okay, so that's the basic concept. That's hypertension leading to hyaline arteriosclerosis, less oxygen delivery, fibrosis, glomerulosclerosis, and decreased GFR. The second one that I want you guys to think about, which is actually becoming the most common cause to chronic kidney disease, is called diabetes. And we actually give this a particular name. We call it diabetic nephropathy, right? But diabetes is by far becoming one of the most common causes of someone developing chronic kidney disease. Now, how does this one work? Let's do this in a different color here. So what happens is, you know, diabetes, son of a gun with these things, huh? They cause a lot of glucose to increase within the bloodstream, right? Now, you know what happens with that glucose? This glucose, you know, there's particular types of things that circulate within our bloodstream. And what it'll do is it'll combine with molecules like proteins and lipids. It'll actually kind of, non-enzymatically, that's the key term here. Let me actually write that down here. It's called non-enzymatic because we're going to have this step here where glucose is going to combine with proteins and lipids. And when it combines with it, it makes these really nasty pro-inflammatory molecules. Makes these really nasty pro-inflammatory molecules. What is this step called here, though, where glucose combines with proteins and lipids in the absence of an enzyme? It's called non-enzymatic glycation, okay? Now, non-enzymatic glycation occurs a lot in patients with diabetes. And these nasty pro-inflammatory molecules, guess what they do? They really love to cause damage to the actual vessels. And you know which vessel they love to hit? What is this vessel? So if we have blood going in, this is the afferent arteriole, moving through the glomerulus, and then exiting out via the efferent arteriole, correct? Now, if these pro-inflammatory molecules start causing lots of inflammation of the efferent arteriole, guess what it leads to? It leads to arteriolosclerosis. And there's two types. You know what two types happen here? One is there's lots of hyalinosis. So what would that be called? You have what's called hyaline. You know, hyaline arteriosclerosis is kind of like a proteinaceous deposits within the vessel wall. So there can be a hyaline arteriosclerosis, or it can actually be plaques. So it can be what's called atherosclerotic, right? So you can develop these fatty plaques that develop within the vessel wall due to a lot of inflammation. And that glucose really increases the risk of oxidization of LDL particles and lots of deposition. Either way, you get arteriosclerosis, whether it be hyaline or whether it be atherosclerotic. The overall effect is nonetheless is the same. If you cause, let's do it here in blue, you cause thickening of this actual efferent arteriole, look at what happens here. Now, imagine you have a nice afferent arteriole where blood is coming in, it's going into a glomerulus, which is like the funnel where things are going to kind of spray out. But then on what's supposed to drain the glomerulus, it's really narrow. What do you think is going to happen to the pressure proximal to that efferent arteriole? It's going to be higher, right? And so what happens is, it's weird, and no, it may not make sense right now, but that pressure, it's going to affect the efferent arteriole. And the efferent arteriole is going to lead to an increase in a back pressure. And that's going to lead to an increase in the glomerular filtration rate. Now that may seem confusing, but hold on, right? It's going to start causing a hyperfiltration process. Now, remember those good old mesangial cells? They do not like it sometimes when your GFR is out of whack. And so they have to try to be able to protect us, these good old mesangial cells. So when the GFR gets high in a hyperfiltration process, it actually stimulates those mesangial cells. And the mesangial cells, in response to that, start secreting, what do they secrete up there? Transforming growth factor beta. When they start making all this transforming growth factor beta, what is it going to do? It's going to stimulate extracellular matrix release. So this is going to lead to fibrosis. What is that fibrosis going to lead to? Glomerulosclerosis. And what is that glomerulosclerosis going to do over time? Drop the GFR, because it's going to cause so much thickening of the actual glomerular basement membrane and nearby structures, right? So as a result, we use that pink, they start releasing a lot of that, transforming the growth factor beta, that stimulates those mesangial cells and nearby fibroblasts to secrete lots of extracellular matrix and leads to a lot of fibrosis of nearby areas. And sometimes this actual fibrosis can occur in like these like big nodules. Sometimes you can get lots of sclerosis that occurs in like very thick nodules. We actually call those Kimmel-Steele-Wilson nodules. Okay, so Kimmel-Steele-Wilson nodules. But again, the overall effect of this arteriosclerosis is that it's going to lead to a back pressure, a hyperfiltration, and then kind of a secondary effect as a protective mechanism. But you know what else can happen is if you have lots of arteriosclerosis of the efferent arteriole, you know efferent arterioles are supposed to, they give off things called vasa recta, peritubular capillaries. The efferent arteriole gives off branches that supply oxygen to the tubular cells. So guess what else can happen is you get decreased oxygen delivery to who? To the tubules. And that may lead to tubular disease. And that tubular disease will affect the ability to be able to have good reabsorption, secretion processes. So that's really important as well. And then over time, that may also lead to a reduction in the GFR. Okay, we have a basic understanding of diabetes and hypertension. Now the next thing, let's move up and let's talk about another condition called glomerulonephritis. All right, so the third cause that I want you guys to remember is called glomerulonephritis. So by far the two most common ones that you guys definitely don't want to forget is going to be hypertension and diabetes. Diabetes being the most common one up and coming, right? The other one that's kind of like the third common cause is glomerulonephritis. But again, take into consideration that this is not a super common cause. So glomerulonephritis, there's so many different types, right? We're not going to go through all of the different types of glomerulonephritis, but usually in glomerulonephritis, this can happen in things that, you know, autoimmune diseases like lupus. This can happen in things like rheumatoid arthritis. This can happen secondary to infections, to HIV or hepatitis viruses, right? So in certain scenarios, your body develops this reaction to, again, an autoimmune reaction, an infection type of process, and they start to produce antibodies, okay? Whether it's against the infection, whether it's against your own tissues. And so you develop this abnormal kind of antibody antigen type of complex. So what is this called? This is called a antibody antigen type of complex. And you know what these things do? They love to deposit into the area of the glomerular basement membrane. So sometimes these antibodies will actually attack certain types of antigens inside the glomerular basement membrane, or they'll attach to particular antigens in the body, like extracellular ones, and then deposit into the glomerular basement membrane. Either way, it activates an inflammatory reaction, complement proteins, white blood cells, all of that stuff. And then you end up with this inflammatory and destructive lesions of the what? The glomerular basement membrane. So you start having damage to the what? Imagine here, you have different parts of the glomerular basement membrane, right? So you have damage to the endothelial cells of the capillaries of the glomerulus. You have damage to the basement membrane, which is made up of different types of proteins. And you have damage to this inner kind of lining of the Bowman's capsule, which is the podocytes. And as you have damage to this, it may make this glomerular basement membrane more porous. And in response to that kind of increase in porosity, what happens as a result? So you have this antigen-antibody complex deposits within the glomerular basement membrane deposition. This increases your inflammatory reaction, and that may cause complement proteins, that may cause white blood cells to come to the area, but eventually it leads to destruction of glomerular basement membrane. And then as a result, now things that are coming through the afferent arteriole, they run through the glomerulus and they're supposed to exit via the efferent arteriole. Look at the porosity now. It's increased porous, or it's increased porosity. And so you're going to have a hyperfiltration process, right? You'll have a kind of an initial increase in GFR. You may leak certain types of things into the urine as a result. But over time with that high GFR, what do your mesangial cells say? Hey man, I'm not a big fan of all this filtration, my bro. We got to chill this down. I don't like all this injury to the glomerulus. I don't like all this hyperfiltration process as a result of the injury. So when you have this destruction and it leads to a hyperfiltration process, it stimulates those good mesangial cells, we'll call them the mesangium, to release transforming growth factor beta, which leads to fibrosis. And then eventually glomerulosclerosis, and then that will lead to a reduction in the GFR over time as you have enough sclerosis and fibrosis, right? So over time, you'll have lots of fibrosis that'll occur here, that'll thicken up the glomerular basement membrane, and that'll affect all of the filtration process, and the end result will lead into a reduction in GFR. This can happen in conditions that can happen rapidly, called rapidly progressive glomerulosclerosis, or maybe focal segmental glomerulosclerosis, but either way, glomerulonephritis over time can lead to chronic kidney disease. The next cause, that is another one I want you guys to be able to think about here, is what's called polycystic kidney disease. We're going to abbreviate this, polycystic kidney disease. And there's two types, autosomal dominant, autosomal recessive. Let's not worry too much about that right now. We'll have another video specifically on that. But all polycystic kidney disease is imagine these tubular cells, because of certain types of gene defects, they have these dilatory kind of portions where the tubules are just kind of like puffing out, right? So there's an outpouching and growth or cysts of multiple different tubular cells due to what's called fibrocystin gene defects. Now imagine here that, let's say here's this nephron, right? Bunch of different cysts that are developing along the length of the nephron. Imagine here, going to this nephron here, you have your afferent arteriole and then exit out via the efferent arteriole. Same thing over here. You have an afferent arteriole, exit out via the efferent arteriole. What happens, and again, this happens when you have really significant cysts within the kidneys. You have a bunch of different cysts of one nephron and it's starting to compress. It's starting to squeeze and compress this nearby vessels. Look at that, you see how that's compressing there? That leads to a reduction in blood flow to the actual glomerulus. Or it may compress maybe the efferent arteriole and reduce the actual blood flow to other parts of the kidney tubules. So if you have these cysts that are causing compression of nearby renal vasculature, so it's compressing renal vessels, that can lead to a reduction in oxygen to the actual kidney tubular cells. So what happens is if I cause a reduction in oxygen to the proximal convoluted tubular cells, the loop of Henle, the distal convoluted tubule, the collecting duct, I affect all of the actual tubular function, reabsorption, secretion of substances. That's no bueno, right? And what if I actually lead to a reduction in blood flow? Because if I'm compressing this afferent arteriole, I'm going to have less blood moving into the glomerulus, right? Because of this compression effect. And so because of that, not only can this decreased oxygen lead to ischemia, and then obviously maybe even necrosis, but this may also lead to a reduction in the GFR because you're having less blood moving through the afferent arteriole and into the glomerulus. And you know what that does? That stimulates, you know what, there's special types of cells in the afferent arteriole called the juxtaglomerular cells. And you know what they do whenever there's high amounts of, whenever there's low GFR? They blast out renin. And when they blast out renin, it increases the activity of the renin, angiotensin, aldosterone, ADH system. You know what angiotensin 2 will do? It'll clamp down on all these blood vessels and it'll try to increase your blood pressure. What does high blood pressure over time lead to? We already said chronic kidney disease via the glomerulosclerosis. So this may lead to glomerulosclerosis. And then over time that may drop your GFR. This is a specific type of hypertension. We call this a secondary type of hypertension. So because of this, we have an idea now how polycystic kidney disease, the cyst can compress the renal vessels, which can lead to a reduction in GFR, renin, angiotensin, aldosterone system, and secondary hypertension, which can lead to, we already know hypertension causes CKD, or it can cause ischemia to the actual kidney tubular cells, causing tubular disease and decrease in reabsorption and secretion. The last one that I want to talk about here is actually one of the most interesting ones, I think, because we often see people utilize these very, very often, and it's called NSAIDs. So sometimes in patients who utilize NSAIDs, overuse of them particularly, it's a very interesting kind of mechanism. You know your afferent arteriole, beautiful little guy here, and then you have your efferent arteriole. Blood should move through the afferent arteriole, come down through the glomerulus, filter out, we know the whole deal, and then exit out via the efferent arteriole. Well, you know there's particular molecules in this area. You know there's molecules that are released here that help to keep this afferent arteriole nice and kind of plump and open so that blood can move into it and have good filtration. Well, you know these molecules are called prostaglandin I2 and prostaglandin E2. And you know what they normally do? They normally try to stimulate vasodilation of afferent arteriole because that allows for good glomerular blood flow and good glomerular filtration rate, right? That's what we want. We want to keep those little guys open. In patients who utilize NSAIDs excessively, tons and tons of NSAIDs, it actually inhibits the PGI2 and prostaglandin E2 production. You know why? Because these act on that cyclooxygenase enzyme, the COX enzymes, keep your mind clear. They work on those enzymes and inhibit prostaglandin production. If you inhibit prostaglandin production, you lead to less vasodilation. And then, as a result, you cause vasoconstriction of the blood vessel, reduction in glomerular blood flow, and then an ultimate result in reduction in GFR. And if this happens over a long period of time, maybe 3+ months from analgesic overuse, what this may result in is a low GFR leading to chronic kidney disease. But boom. The last one that I want to talk about, it's probably one of the easiest ones to remember, we don't even need to write it down, is if someone had an acute kidney injury, which is usually what? They have an acute kidney injury, it's usually less than or equal to 3 months. But if it's, I'm sorry, let me start that part over.
Yep.
And the last cause that I want to briefly talk about, because it's probably one of the easiest ones that doesn't deserve a lot of discussion, is when someone has an acute kidney injury. They develop a very significant acute insult to the kidney, and it doesn't actually heal. It's a progressive, continuous acute kidney injury, or very frequent acute kidney injuries over time can lead to chronic kidney disease. All right, now that we covered the causes, let's go over the pathophys. All right, so let's talk about the pathophysiology. What we want to do is we want to bridge the understanding of how whenever there is these causes that we discussed, diabetes, hypertension, glomerulonephritis, polycystic kidney disease, NSAID overuse, acute kidney injury that has not been treated or it's progressing in more frequent AKIs, whatever it may be, how do these things lead to the particular clinical manifestations, complications, and help us diagnose CKD? First thing you have to remember is all the basic functions of the kidney. Remember we said one of them was electrolyte balance? So guess what one of the things that we will see is electrolyte abnormalities. Okay, so we may see some signs of electrolyte abnormalities. Now this is not that hard. You know, the kidneys are responsible for excreting two particular types of ions. One of them that it loves to excrete is potassium. It's supposed to be excreting the potassium, and it's supposed to be excreting phosphate. But in a patient who has a reduction in their glomerular filtration rate, they'll have less filtration of the potassium, less filtration of the actual phosphate. And so because of that, they're going to have an increase in their potassium and an increase in their phosphate process. Also, another thing with this is that usually in these patients with the high potassium, it may also be related because if they have tubular damage, potassium is supposed to be secreted by the kidney tubules. If there's kidney tubular damage, they won't be excreted. So again, that's another process as well. So we have an understanding here that whenever there's high potassium, high phosphate. All right, another particular electrolyte that actually becomes abnormal is not just the ability to inability to excrete potassium and phosphate, but also our kidneys are very good. We'll talk about it a little bit later with respect to the hormone imbalance. But when the kidneys are damaged, particularly the proximal convoluted tubular cells. The proximal convoluted tubular cells contain an enzyme called alpha-1 hydroxylase. And basically the simple mechanism of this is it takes, our liver makes a molecule called 25-dihydroxycholecalciferol, all that crap. All I want you to know is that it stimulates and activates vitamin D. I just want you to know that it activates vitamin D. Okay, this enzyme that's made by the kidney. But if there is a decrease in this enzyme because of a defect or decrease in the kidney function, there'll be a decrease in the activation of vitamin D. Why is that important? What vitamin D helps to be able to do? Increase calcium absorption across the gut. So now if you have a decrease in vitamin D, the calcium that you're supposed to be absorbing will reduce, and so you can result in calcium hypocalcemia. So some of the signs that I want you guys to remember is this may lead to a hyperkalemia, hyperphosphatemia, and hypocalcemia. Now sometimes the sodium is a little tricky. We're not going to go too deep down the rabbit hole here, but in certain scenarios, generally in the beginning stages, you may retain kind of fluid in CKD, and if you have a retention of fluid, it may drop the sodium, causing a dilutional hyponatremia. But as the GFR gets really, 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 really bad, your ability to excrete sodium significantly decreases. So the worse the GFR is, the worse the sodium excretion is. And sometimes that can cause hypernatremia. So in certain scenarios, the sodium level can be kind of fluctuated. So the big electrolytes that I want you to remember is hypocalcemia, hyperkalemia, and hyperphosphatemia. Okay? Let's talk about the second cause. Okay, so the next thing is, the kidney is not only important with electrolyte balance, but it's also important with water balance. So what happens if you have a decreased function of the kidneys? The ability to maintain water balance is lost. And so you develop a water imbalance. So simple, right? So your kidneys, whenever you have a reduction in the GFR, it's the amount of filtrate, and within the, particularly the amount of plasma actually, within the actual blood vessel that you filter across the glomerulus and into the actual kidney tubules. If there's a reduction in the GFR, there's a reduction in the amount of plasma, water, solutes, that you're pushing out of the glomerulus and into the kidney tubules. So a reduction in GFR will result in decreased water filtration. And as a result, this will lead to what? An increase in water retention in the actual blood vessels. Now, if there's an increase in water retention, you're holding on to more water, that water can actually start depositing into multiple different tissues, like the lungs, right? It could also cause effects on your cardiovascular system. It could also accumulate in the actual lower extremities of the legs. What could this lead to? What is this called when you have lots of fluid that develops within the lungs as a result of water retention? This can lead to what's called pulmonary edema. What can happen if you have an increase in blood volume and it's enough to actually increase the pressure within the vascular system? Hypertension. What's it called whenever you have swelling of the lower extremities? Peripheral edema. So these are the things that I want you guys to think about that may be a result of water retention. This may lead to volume overload, right? So this may lead to volume overload states. But here's another thing that I want you to think about. You know when the kidneys are really badly injured? When the kidneys are really badly injured, they start to dump a lot of another protein in the urine. You know there's a protein that they empty into the urine because of the damage to the kidney tubules and the damage to the glomerulus? They put a protein here called albumin. So you put a lot of albumin in the urine. It's called albuminuria. As the albumin in the urine actually starts to increase, what happens to the albumin in the blood? It starts to decrease, right? Because you're excreting it. What does albumin do in the vessels? It keeps water in the vessels, right? It's supposed to generate an osmotic gradient to keep water in the vessels. If you have less albumin in the blood, are you going to be able to maintain water in the vasculature? No. And so because of that, there is a loss of water into the interstitial fluid. And as a result, that can lead to these volume overload states. It may start accumulating interstitial fluids of the lungs, causing pulmonary edema, interstitial edema. It may actually not cause too much hypertension, but it may also cause a lot of this peripheral edema. Okay, because the only reason it wouldn't really cause hypertension if it's leaking out of the vessels, it's not truly in the vessel. But it will cause pulmonary edema and peripheral edema in this response to hypoalbuminemia due to albuminuria from chronic kidney disease. Okay, so that's the water imbalance. Now let's talk about the third type of abnormality there. The third one that I want you guys to remember is a really big one. This is actually super high yield. You guys definitely can't forget these, okay? This is actually, son of a gun, it's important for waste removal, right? It's important for waste removal. But you know the big waste that I really want you guys to remember, especially in chronic kidney disease, is urea. And you know what happens when you have lots of kidney damage and the urea starts to build up? You know what we call that? We call when the urea is just building up. Just when it's building up, it's not causing actual organ damage or tissue damage. It's called azotemia. But when it gets to the point where the azotemia actually starts exerting its effects on peripheral tissues and causing organ damage, what's that called? Uremia. So that's what I want you guys to remember. So this next thing that I want you guys to talk about is uremia, and this is due to an inability to maintain or remove waste products like urea. Now, how may uremia present? You know, it can actually accumulate in the blood and cross the blood-brain barrier, cause cytotoxic effects on the neurons, and it can cause encephalopathy. Now, encephalopathy is kind of a very generic, like umbrella term. There's a lot of things that could be consisting within that. One of the big ones for your exams is if you take a person's hands and you kind of extend it quickly, they have like this flapping kind of tremor of the hands. It's called asterixis. So these are one of the big kind of like buzzword terms that I want you to remember. It may also cause seizures. It may cause hyperexcitability of the neurons. Sometimes if it's really, really high, it's enough to actually put a person into a comatose state. But sometimes it can be very like generalized symptoms, such as kind of just, fatigue, being very weak, sometimes nausea, vomiting, things of that nature. So it can be very generalized, non-specific symptoms. But the big ones that I want you to remember is asterixis is the big one, seizures and coma. Okay, the second thing is it loves to agitate. You know there's a fibrous tissue here. Well, there's a fibrous tissue and kind of an epithelial tissue that kind of overlies the heart. What is this tissue here called? This is called your pericardium. You know the pericardium, it actually is very susceptible to high levels of urea, and it causes inflammation of the pericardium. And sometimes that inflammation causes a lot of fluid to be secreted into the actual pericardial cavity. What is that called when you have lots of fluid and inflammation of the pericardium? Pericarditis. So this can lead to what's called uremic pericarditis, And sometimes this uremic pericarditis can actually lead to pericardial effusions. You know what else it can do? You know, this urea, it's in the blood, right? And so because it's actually flowing through the blood, there's a lot of this urea within the blood, it gets into our sweat glands from the blood, you know, because we utilize particular plasma substances from our blood. The eccrine sweat glands use particular things like water, salt, things of that nature to make sweat. So urea leaks into the sweat glands, and you actually start putting some of this urea into the skin, and it actually kind of crystallizes and produces something called uremic frost, which can show up on the skin, okay? The next thing is that it also really affects the platelets. You know, whenever there's lots of urea, it affects the platelets from being able to kind of stick to one another. And so if you affect the platelets from being able to kind of stick to one another, you affect the ability to be able to clot. So now the platelets aren't going to want to be able to sticky as much. So they have what's called a platelet dysfunction. And so this leads to this platelet dysfunction increases the risk of bleeding. What is that called when you have an increased risk of bleeding? Coagulopathy, right? So this can increase your bleeding risk or cause an underlying type of coagulopathy. So these are the big things I want you to remember as potential clinical manifestations of severe CKD. All right, we know that it's important for electrolyte balance, water balance, removal of waste products and drugs. The next thing that I want you guys to remember here is that it also has an effect on hormones. So if we lose the ability to function to make hormones, we have hormone imbalances, right? Okay, so what are some examples of some hormone imbalances? Well, you know the kidney, it's a very cool thing. The proximal convoluted tubular cells, they make a very beautiful hormone called erythropoietin. We call it sometimes EPO, right? So erythropoietin will stimulate the red bone marrow. You know, within particular bones, it acts on like the red bone marrow and like particular long bones and flat bones and things of that nature, and stimulates the red bone marrow. So we'll put red bone marrow. It stimulates them to undergo a process called erythropoiesis. What is that called? Red blood cell production. And so as a response to this, you'll make red blood cells. Well, if you have chronic kidney disease, what happens to those proximal convoluted tubular cells for whatever reason? The ability to make EPO goes down. If EPO goes down, your ability to stimulate the red bone marrow becomes inhibited, and your ability to make red blood cells drops. What is it called when you have decreased number of red blood cells? Anemia. And this anemia is due to a disease, so we actually call this anemia of chronic disease. Okay? So that's an important thing to remember. Okay, what's another thing that it actually does? Another hormone, very interesting. You know, whenever the kidneys are really damaged, we've already talked about this. Usually what ends up happening is the kidneys become damaged in some way, shape, or form by any of the causes that we discussed. And as their renal function goes down, what do we say really happens? Their ability to make urine goes down, right? So eventually they have what's called a reduction in their GFR. Now, those juxtaglomerular cells are very sensitive. They still work in chronic kidney disease. They're actually hyperfunctional sometimes. And because there's a reduction in GFR, right, you actually cause less blood flow. There's a reduction in GFR. It's sometimes what happens is your JG cells interpret that as low blood flow. And what happens is they start blasting out a particular hormone called renin. You know what renin does? Renin activates your renin, angiotensin, aldosterone, ADH system. But the big one that I want you to remember here is angiotensin 2. And angiotensin 2, when he's stimulated, he's going to act on the blood vessels, cause intense vasoconstriction of the blood vessels. What happens if I cause vasoconstriction of multiple arterioles in the body? I'm going to cause an increase in my systemic vascular resistance and an increase in blood pressure. So as a result, blood pressure can cause chronic kidney disease, but then you can develop a secondary worsening type of hypertension related to the chronic kidney disease. So this is called a secondary hypertension. Okay, so we have two aspects here. One is anemia due to decreased erythropoietin, and in a reduction in GFR, it increases your renin production, increases the activity of renin and angiotensin aldosterone system, increases angiotensin 2, increases vasoconstriction, and increases your blood pressure. Also, ADH will be released, And if the kidney tubules are functional, they'll reabsorb water, which will cause water retention, increase in blood volume, increase in blood pressure. And if the kidney tubules are functional to sodium, they'll reabsorb sodium, and so it may cause hypernatremia as well. Okay, but the big thing here is the angiotensin II effect. Now, let's talk about the last hormone effect. All right, the last type of electrolyte imbalance that I want you guys to remember here is, we talked about it very, very briefly, but it's related to calcium. Now, remember we said that whenever the kidneys are super jacked up, they're damaged, their ability to make an enzyme as a result in the proximal convoluted tubular cells. What was that enzyme? Alpha-1 hydroxylase. The enzyme production is decreased because the kidneys are damaged. So their ability to make this enzyme is decreased. Why is this important? You know, our liver, it takes like an inactive, we'll put inactive vitamin D that we get from like our skin. Look at that, that's actually perfect. Inactive vitamin D from our skin, cholecalciferol, goes to the liver. The liver adds a hydroxyl group on it called 25-hydroxycholecalciferol, and then this enzyme is supposed to work right here in this step to convert the 25 into what's called 1,25 dihydroxycholecalciferol. Remember I told you that in a roundabout way, this is active vitamin D. That's all I wanted you to kind of remember. Well, if this is reduced, this pathway isn't going to happen as often. So in response here, you have less of the alpha-1 hydroxylase. There's a decrease in this conversion process. So you result in less of active vitamin D. In response to low vitamin D, what do you not absorb as much? Calcium. So in response to this, there is a decrease in calcium absorption. What does calcium, low calcium, trigger? You know, within the back of the thyroid glands, you get these like little baby glands on the superior and the inferior aspect. What are they called? Parathyroid glands. They're so sensitive to low calcium. In response, they're like, uh-oh, my baby's low. I gotta start increasing some more of my babies. So it increases the production of what's called parathyroid hormone. But this hyperparathyroidism is actually not due to the parathyroid gland itself. It's not a primary problem with that. It's actually maybe a secondary problem due to the chronic kidney disease. What does that hyperparathyroid hormone do? Well, you know it's supposed to act on the kidneys and reabsorb calcium. But if it tries to do that, are your kidneys functional? Are they able to reabsorb calcium? No. It's not going to be good at that. And we already have less vitamin D, so there's only one other source that PTH can kind of draw from, the bones. And so you know what PTH does? PTH goes and acts on osteoclasts. You know there's bone breaking cells called osteoclasts? It really hyperactivates these osteoclasts and they start breaking down bone. This causes lots of bone resorption because the overall effect is that the bone resorption will try to liberate calcium from the bone and into the blood. But if this is the only source that you can try to increase calcium, this pathway is going to be hyperactive. You're going to be resorbing tons and tons of bone. And this will start leading to lots of nasty diseases. One of them is called renal osteodystrophy. Another one is called osteitis cystica fibrosa. And then the other thing is if you're kind of breaking down lots of bone, you make it very porous, you're increasing the risk of fractures. So lots of nasty things can happen as a result of this secondary hyperparathyroidism, such as renal osteodystrophy, osteitis cystica fibrosa, and fractures. Lots of nasty stuff. So that's another potential result of chronic kidney disease. Okay, so we covered hormone imbalances. You know what else the kidney is really good at that we talked about? Its ability to maintain acid-base balance. But you have damage to the kidney cells. So if you have damage to the kidney cells, you know there's particular cells within the kidney. You have what's called like the alpha intercalated cells. They're within like the distal convoluted tubule collecting duct. They're responsible for secreting like protons into the urine. So that's what they want to do, is they want to put protons into the urine. But you have chronic kidney disease, so you have damage to lots of different cells here. So your ability to reduce, your ability for these cells to secrete protons is reduced. So what happens to the amount of protons that actually accumulate within the blood? it increases. You know what else? In other parts of your kidney tubular cells, you have other cells that are supposed to, you have alpha intercalated cells as well, other types, and other types of cells that are supposed to increase your bicarb absorption. We should actually say reabsorption. So you actually filter bicarb across the glomerulus, and you're supposed to reabsorb some of it. But if your kidney tubules are damaged and you aren't able to reabsorb bicarb, what happens? And as a result of a decrease of these intercalated cells and other cells, there's a decrease in bicarb reabsorption and a decrease in proton excretion. So you increase your proton concentration and you effectively reduce your bicarb reabsorption. So a lot of the bicarb ends up in the urine. So tons of bicarb will end up in the urine. As a result, what is this called when you have an increase in protons, a decrease in bicarb that reduces your pH? What is this called? This is called a metabolic acidosis. That's another thing I want you guys to remember, okay? So there's a reduction in the ability to excrete protons and the inability to reabsorb bicarb. So protons don't get produced in the urine. Bicarb does end up in the urine. When you have an increase in protons and a decrease in bicarb, that drops your pH, causes a metabolic type of uremic acidosis. Okay, the last type of effect here that I want you guys to remember. Whenever you have, let's find another cool, here, we'll use brown. So another effect here is your kidneys are not only important for all of the things that we just discussed, but it also kind of plays a role within like proteins, albumin regulation, and in an indirect way, lipid synthesis. So it also does have a role on albumin. We kind of already touched on this, albumin regulation in a way, okay? So when our kidneys are damaged, right, they maybe become more porous and then they start spilling albumin into the urine, right? That effectively lowers the albumin in the blood. As a result, we already know what that does. We said that it actually will cause third spacing of fluid. It will cause third spacing of fluid, right? Because you're not able to keep water in the blood vessels. But whenever you have a decrease in albumin, you know what it does to your liver? It tells your liver, hey man, there's less proteins, bro. You gotta start making some proteins. And so the liver, in response to this decrease in albumin, starts increasing the amount of proteins that it's trying to make, okay? And it may try to increase proteins like albumin, but one of the proteins that it actually increases? Unfortunately, it increases your lipoproteins. And lipoproteins are important for things like LDL, things like HDL, things like triglycerides. And you know what happens as a result of this increase in protein synthesis? You increase the amount of triglycerides and you increase the amount of LDL. And you end up with hyperlipidemia as a response. Oh no. So that's not good, right? So we have an idea here of all the particular complications and clinical manifestations that may be present in a person with CKD. Now let's hit it home with some diagnostics and treatment. All right, so let's talk about the diagnosis of chronic kidney disease. It's actually not too bad. And again, it's more of a clinical diagnosis. So we have to have at least 3+ months of evidence of kidney injury, right? So it has to at least have you have to definitely have a very good history of the patient, but 3+ months of, kidney injury, some kind of marker of kidney injury. Now, what are the markers that we utilize for kidney injury? Okay, for 3+ months, we're trying to mark, okay, what was their kidney function like over this time period? And so some of the things that we can use is actually one of the most common ones that we talked about over there is GFR. Okay, so we can utilize our GFR as one of the ways to determine a sign of kidney injury over the past 3+ months. So GFR is, again, what's our normal kind of number for GFR? The normal number, so your normal GFR, if we were to say an average GFR, is somewhere around 125 milliliters per minute, right? That's about the average GFR. As renal function declines, your ability to filter out this volume starts to go down. The ways that we try to estimate a glomerular filtration rate is we can do this via two mechanisms. One is you can estimate this. So you can estimate GFR based upon what's called your creatinine, or you can do it based upon another way, which is a lot more accurate, another molecule called cystatin C. But there's a bunch of different types of formulas and calculations and MD Calc that you guys can just go pull up to calculate GFR, estimate GFR. These are ways that we can kind of do that. Now, what is the big thing that I want you guys to know is not just the ways that we estimate or calculate GFR. That's, we can pull that up on MD Calc. What I really want you to understand is the degree of kidney disease is kind of dependent upon the number of the GFR. Okay, so we have different staging, if you will, of CKD based upon their actual GFR. As the GFR increases, as the GFR decreases, the level or severity or stage of the chronic kidney disease is going to be increasing. So generally the first stage is going to be anywhere that's normal. So greater than or equal to 90 is going to be in milliliters per minute for their GFR, okay? Then if it's stage 2, it's anywhere from 60 to just below 90, which is 89. 3, there's actually 2 types. There's 3A and there's 3B. 3A is you have to go just below 60. And so it's going to be 45 to 59. And then 3B is going to be 30 to 44. Stage 4 chronic kidney disease is going to be anything that's usually 15 to just one below 30, 29. And then if it's less than 15, that is going to be stage 5 chronic kidney disease. Okay? So again, one of the ways that we can diagnose chronic kidney disease is actually having a history of 3+ months of evidence of kidney injuries, markers of kidney injury. And one of the markers is a reduction in GFR. You can calculate GFR by a bunch of different equations, but the 2 basic ways that we calculate it is dependent upon the creatinine or the cystatin C type of assay. Either way, whenever the GFR is decreasing, that determines the stage of chronic kidney disease, okay, as we mentioned right here. Now, what's another way that we can determine chronic kidney disease? Not just this actual GFR. Another way that we can actually determine it is based upon what's called albuminuria, which is how much albumin is being released into the urine, right? That's, this is actually a predictor of disease, like severe disease. So in other words, the more albuminuria is, the more kind of severe the disease will actually be. So it's kind of a predictor of disease. So again, albuminuria is how much albumin we're actually losing in the urine, because if there's severe kidney disease, your ability to regulate the albumin across the glomerular basement membrane is lost, and you lose albumin into the urine. Now, when we actually do this, we utilize a urinalysis study. Okay, so we actually have to test urine because that's what we're testing, is albumin in the urine. So we utilize a very specific type of test, and it's called a urine albumin to creatinine ratio. So we're taking the urine albumin, or what's called a spot urine albumin creatinine ratio. Now, when you do that, there's a couple different numbers that we're looking at. Mild is when the albumin creatinine ratio is less than 30. Moderate is when the albumin creatinine ratio is 30 to 299. And then severe is when the albumin creatinine ratio is greater than or equal to 300. Another way that we determine, we can actually use terminology here, is whenever it's moderate albuminuria with an albumin creatinine ratio of 30 to 299, it's called microalbuminuria. And whenever the albumin creatinine ratio is greater than or equal to 300, or severe albuminuria, it's called macroalbuminuria. Okay? Alrighty. Now, that is the 2 ways that we can kind of determine CKD. One is 3+ months of evidence of kidney injury via reduction in GFR or albumin within the urine. All right, so the third thing that we could actually do is we could actually do what's called a renal ultrasound. Now, this renal ultrasound, what is the whole purpose of this? Well, it can tell us a couple different things. It can help us one way to actually find one of the causes of chronic kidney disease. So we can obviously test for diabetes, right? You test the hemoglobin A1C, you test their random blood sugar, their fasting sugar, oral glucose tolerance test. That's an easy way to determine diabetes. Hypertension, if their blood pressure has been greater than or equal to 140/90 for at least 2+ readings, that's an easy way of diagnosing it. What was another particular cause that we talked about? Polycystic kidney disease, right? So if you get a renal ultrasound and you see like a bunch of cysts all over the place, that may help you to say, oh my gosh, they have polycystic kidney disease. That may be the reason why this person has chronic kidney disease. The other thing is, in chronic kidney disease, as there's consistent damage and fibrosis, the kidneys actually get kind of smaller. And so you end up with these small kidneys, and they also end up very atrophic. Okay, so you end up with these small, kind of atrophic, fibrotic kidneys. That's one kind of evidence of potential chronic kidney disease. Small, atrophic kidneys with a decreased GFR and albuminuria, or cysts of evidence of polycystic kidney disease. Another one is you can kind of look at the vascularity. As kidney disease kind of progresses, the vascularity can become affected. And so another thing that we actually look for is kind of a decreased perfusion. We can use Doppler for the ultrasound, and maybe you see a decreased perfusion of the kidneys, or just in general a decrease in vascularity due to the fibrosis that occurs with chronic kidney disease. So these are things that you can do, but the big one that I really want you to kind of take into consideration with renal ultrasound is the polycystic kidney disease. That might be one way to find the underlying cause, okay? Okay, the next thing is, if we've determined that they have chronic kidney disease with evidence of kidney injury by GFR, albuminuria. We found one of the causes with renal ultrasound. We maybe saw that they definitely have small atrophic kidneys with decreased perfusion and vascularity. We've looked to see if they have diabetes. We looked to see if they have hypertension. What was another particular cause? Glomerulonephritis, right? Glomerulonephritis is actually not super easy to diagnose. So maybe they have red blood cell casts, maybe they have dysmorphic red blood cells, maybe they have albuminuria, maybe they have other signs of potential glomerulonephritis. But really the way that we kind of get about that determination is we actually have to do what's called a renal biopsy. So you may need what's called a renal biopsy, and you may even need serology, because again, glomerulonephritis is kind of like a syndrome of there's underlying causes to glomerulonephritis that you have to elucidate what was the cause of it. So when you do a biopsy, you're basically taking a piece of the actual tissue and looking at it under the microscope. So we would actually take a piece of tissue here and we would look at it under the microscope, and we would do different types of studies. Maybe different types of immunofluorescence studies, maybe different types of ELISA studies, but we're trying to determine is there any evidence of glomerulonephritis, a minimal change disease, a focal segmental glomerulosclerosis, so on and so forth. And then the other thing that you can do here is you can also do serology, because what did I say? Usually glomerulonephritis could be autoimmune related. So you may check an ANA for lupus, you may check a rheumatoid factor for rheumatoid arthritis, right? You may check, vasculitides can actually cause this. Good pasture scent disease and other different types of vasculitides. So maybe Wegener's and Churg-Strauss and things of that nature. So maybe you have to check things like ANCAs, P ANCAs, C ANCAs. What did I tell you? Infections like HIV. Check things like hepatitis viruses, okay? So these may be things that you have to do in addition to the renal biopsy to kind of look for what is the cause of their glomerulonephritis, and do they have glomerulonephritis, and what kind do they actually have. So that's another thing that you might have to go through. Okay, now that we've done that, the last thing that you can actually do here is, again, we have kind of gone through all the diseases, right? We determine if they had diabetes, hemoglobin A1C, fasting sugar, oral glucose tolerance, determine if they have hypertension, greater than equal to 140/90 for at least 2+ readings, ultrasound for polycystic kidney disease, renal biopsy and serology to look for any glomerulonephritis. We can do the serology associated with that. We can also see, do they take NSAIDs very frequently? We've kind of gone through all of that, and we can also determine if they have any increases in their any issues with acute kidney injuries very frequently. The other thing that we should look for as the complications associated with chronic kidney disease is all the things that we just talked about in the pathophys. So we can do a bunch of different types of additional tests. So we're going to just call these like our additional tests that we're going to do. So additional labs. What do these additional labs tell us? Well, we can check our potassium. What do we say happens with the potassium? It's a good reminder. It usually goes up. What happens to the phosphate? Goes up because inability to excrete these substances. What happens to the calcium? Well, you decrease vitamin D, which decreases calcium absorption. What happens to the sodium? It can either be increased or decrease. It depends upon the severity of the disease. If you're having lots of water accumulation and retention, it may dilute the sodium, causing hyponatremia. But if the GFR is super low, your ability to filter sodium across the glomerulus decreases and you retain sodium. So it can be variable depending upon the severity of the CKD. What happens to the red blood cells? Oh, before we even say that, what kind of lab setting would give me all of these? Potassium, maybe phosphate, calcium, sodium. I may have to order calcium and phosphate as an extra lab, but potassium, sodium, calcium, usually I can get these kind of through one lab. I can get this from a BMP. So I may order a BMP. You know what else a BMP tells you? It should estimate your GFR based upon the creatinine. So a BMP should also give you potassium. It should give you calcium. It should give you sodium. You may have to add on a phosphate. So we'll add on a phosphate. And then it also should give you your GFR, which is based upon the creatinine, okay? Red blood cells, what happens to them? There's a decrease in the erythropoietin. So there is anemia. What do we check for that? A CBC. Now, what kind of anemia is this? Is it normocytic, microcytic, macrocytic? It's normocytic. And so generally, this would be a normocytic, which means that there's a normal MCV. And it's also normal chromic, so normal MCHC as well. But either way, you'd actually want to exclude iron deficiency anemia. You know, if people are getting dialysis and they have CKD, they can actually lose blood from the dialysis, and so they can also have iron deficiency anemia in association with this. So make sure that you actually maybe have to check their iron. You may have to do iron studies as well, just to make sure that they don't also have an associated iron deficiency anemia. What can I do with these protons and bicarb? Well, there's going to be an increase in protons and a decrease in bicarb. What can I get these from? Well, you know you actually can get bicarb from a BMP. You can't get protons from a BMP, but maybe let's say that you checked their BMP and their bicarb was low. You were a little concerned. You check a ABG. An ABG would show you evidence of an acidosis, particularly a metabolic acidosis. What else? What happens to their triglycerides and their LDLs? It would go up. What do I check for that? A lipid panel. And then if I have someone that has really high phosphate, they have very severe chronic kidney disease, what happens to their PTH levels? They should go up. And so what can I do for that? I can check their PTH. Okay, and then the other thing to consider is that sometimes if PTH levels get really high in the severe chronic kidney diseases, even though hypocalcemia is one potential manifestation, guess what can happen? In very severe CKD, this may lead to hypercalcemia. If the PTH gets high enough and the kidneys are super damaged, it may lead to hypercalcemia. Okay, so these are all the ways that we can go about diagnosing CKD. Now let's talk about the treatment of CKD. All right, so when we talk about the treatment of chronic kidney disease, I know we're almost at the end, engineers, just hang out with me, right? So when we're talking about the treatment of chronic kidney disease, it's actually the damage that has been done is you can't reverse that. So what you have to try to be able to do is reduce the actual progression of the disease. So we need to decrease the progression of the disease, okay? And then treat the underlying factors that led to this disease in the first place, okay? Because if we treat those particular causes, that may reduce the further damage, the further injury to the kidneys, which leads to the further severity of their CKD. So then we have to go back and we have to think about what were the underlying causes for chronic kidney disease. Let's test your knowledge. One of them was hypertension, right? So hypertension was a big cause. What were the drugs that would be best suited for treating someone with chronic kidney disease? Well, you got to remember, whenever there's chronic kidney disease, there's a reduction in the GFR, right? In some way, shape, or form. And that reduction in the GFR leads to what? An activation of renin. Renin, if there's an increase in this, leads to the increase in the renin, angiotensin, aldosterone, ADH system. And that's going to increase their blood pressure. What drugs regulate the activity of the renin, angiotensin, aldosterone system? What inhibits angiotensin II formation via the ACE enzyme? You can use drugs called ACE inhibitors. What drugs actually inhibit angiotensin II at the receptors that it works on? ARBs. What drugs actually work to block aldosterone? What? Potassium sparing diuretics, things like spironolactone. So and these may be drugs that you prescribe to patients to be able to treat their underlying hypertension by altering the activity of this renin-angiotensin-aldosterone ADH system. Okay, so that's one way. Okay, what's another way that you can actually control their blood pressure? And actually the next question is, you should use these drugs to approach what kind of blood pressure? What's your ultimate goal with these? The ultimate goal with these is to get to a blood pressure that you're getting at less than or equal to 130/80. But what other things could you do to prevent hypertension? What's another thing that can cause hypertension? Fluid overload, right? We have lots of water. So another thing is that if you have a reduction in GFR, there is a reduction in water loss. And so you end up with increased water retention. What's a drug that you could give to pull water out of the body? Diuretics. So another potential option here is going to be diuretics. Things like loop diuretics may be another option to pull some of that fluid off. And if you pull some of the fluid off, that may actually get rid of the volume overload and lower the blood pressure. The other thing is just kind of sodium restriction and water restriction as well. Those are simple things. If you restrict your sodium intake, you restrict your water intake, that also reduces your blood volume and then your blood pressure as well. So ACE inhibitors, ARBs, potassium-sparing diuretics to alter the renin-angiotensin-aldosterone system, diuretics for volume overload states, and sodium and water restriction. Boom, roasted. Let's move on to the next one. Another particular cause is whenever you have diabetes. In diabetes, it's usually due to high amounts of glucose, right? High amounts of glucose causing that arteriolosclerosis. What can we do to prevent these super elevated glucose levels? What can I give? Insulin, right? So maybe one thing is giving insulin if they need insulin. What if they're a type 2 diabetic? Then maybe it's giving them certain types of anti-diabetic drugs, things like metformin, things like SGLT2 inhibitors, so on and so forth. And also, simply, weight loss, diet changes, right? What kind of goal am I aiming for, though? Like, I'm trying to use these to get to a blood pressure less than or equal to 130/80. What am I trying to use insulin, anti-diabetic drugs, weight loss, diet changes to get to? We aim for a hemoglobin A1C that's at least less than 6.5%, okay? So we got treating hypertension, treating diabetes. What was another potential cause? Another potential cause was glomerulonephritis. So we'll put glomerulonephritis, right? With glomerulonephritis, what was happening? There was a lot of damage to the glomerulus. And this was usually due to some type of antigen-antibody deposition into this area, causing a lot of inflammation. Usually this is related to autoimmune diseases. What are things that we can use to treat autoimmune diseases or inflammatory reactions? Steroids. So sometimes in these kinds of glomerulonephritis, you have to figure out the underlying cause first off. But steroids maybe be an option, and plus or minus sometimes what's called your DMARDs. Okay, these are things like methotrexate, mycophenolate, maybe cyclosporin, all these different things. But again, you have to figure out, treat the underlying cause. Because if you figure out what caused the glomerulonephritis and you fix that, you can again prevent the progression of the disease potentially. All right, what's another one? Polycystic kidney disease. Polycystic kidney disease is actually one of those that you're really just treating the hypertension, the secondary hypertension related to it. But in certain situations where the polycystic kidney disease is really, really bad, what may you have to lead to? Renal transplant. So sometimes this may lead to renal transplant, okay? So sometimes all you're really trying to do is control the secondary hypertension related to it, some of the complications associated with polycystic kidney disease, but the best thing to do in these kinds of scenarios is a renal transplant. Okay, so we've kind of done that, right? What was the last thing I mentioned as another particular cause? We'll kind of squeeze it up here in this right corner. NSAIDs, right? NSAIDs. So discontinuing any kind of nephrotoxic agent should be a general, not just NSAIDs. Any nephrotoxic agent, try to reduce their concentration or try to not use them at all. So discontinue nephrotoxins should be another way that we try to decrease the progression of the actual disease. Okay, boom, yada, yada. Let's manage the complications. This is where a lot of the actual treatment of CKD comes in. So now what we have to do is we have to decrease the complications of CKD, or if all else fails, this may lead to what's called renal replacement therapies, such as dialysis, kidney transplant, things of that nature. Okay, first and foremost was the electrolyte abnormalities. We already know that it's going to cause hyperkalemia, hyperphosphatemia, hypocalcemia, and then the hormone effect related to the hypocalcemia, hyperparathyroidism. How do I treat hyperkalemia? Remember, one of the ways is we can shift the potassium into cells, right? That's one way, is we can push the potassium into cells. We talked about this in our hyperkalemia video. What were the ways that we could do that? We could give insulin, because that stimulates the sodium-potassium pumps and pushes potassium in. We could use things like albuterol, which is a SABA, which is going to activate beta-2 receptors. And we can also sometimes use bicarbonate in the presence of acidosis, bicarbonate as well. We could also pee out the potassium. We could get rid of the potassium if we give a very high dose of a diuretic. So sometimes we may need to give a diuretic, and usually the best one in this case is a loop diuretic, and then plus or minus a thiazide diuretic if you need a little bit of extra pull. Okay? We could also, if the kidneys aren't able, if they're completely anuric or they can't respond to a diuretic, or they're actually like super depleted and you need to actually give them a little bit of fluid in certain situations, you may have to pull out that potassium through the butt. And that's where you may have to use things like sodium polystyrene, which is also known as kyaxylate, to pull it out. Okay, and if these things fail, then you may have to do dialysis. All right, so hyperphosphatemia. Whenever you have hyperphosphatemia, which sometimes you can just try to reduce this by reducing the consumption of phosphorus-containing foods, but sometimes that's really difficult. So imagine you consume lots of phosphorus within the diet. What you can do is you can give a drug called sevelamer hydrochloride. And what this is imagine this kind of like a drug that sops up. Imagine this kind of like a binder of phosphate. It's a phosphate binder, if you will. And what it does is going to pull the phosphate through the gut and actually cause you to poop it right out. And so you don't actually absorb. So therefore, all of this phosphate doesn't get absorbed. It goes right into the toilet bowl. Okay, and as a result, this should effectively try to lower your phosphorus concentration within the blood. Now, low calcium. What way can we treat that? Give them calcium, baby. So give them calcium. So we can actually give them calcium. We can give it in the form of calcium acetate, calcium gluconate, calcium chloride. There's a bunch of different ways, but just giving them calcium in general, it's kind of going to be the easy way. Now, if you actually check their vitamin D levels, and what if their vitamin D levels, their active vitamin D levels are low? What can I do to treat that underlying vitamin D deficiency that they have? Well, I can give them vitamin D. So what else could I sometimes do is if there's low calcium, I can also add on vitamin D, because that may help to increase the absorption of calcium. And in general, if their hypocalcemia could obviously be due to the vitamin D. If their vitamin D levels are low, give them vitamin D, it'll increase their calcium levels as well. So sometimes hypocalcemia is treating it with calcium and vitamin D. Now, we said that hypocalcemia may stimulate the parathyroid glands to make more parathyroid hormone. And in response to that high parathyroid hormone, it's going to try to increase your blood calcium levels, which can happen in the severe disease states, which this can lead to in severe CKD. But in general, if the PTH is getting really high and it's leading to super high calcium levels, okay? So it's leading to super high calcium levels, then we have to address the high PTH and the high calcium. How do we treat this? This is actually called secondary hyperparathyroidism, which can actually sometimes become what's called tertiary if it's severe chronic kidney disease. What we do is we can give a drug that actually tries to block. Imagine this is kind of like a blocker of PTH. So it's going to effectively try to reduce the PTH production. One of these drugs is like kind of like a calcium sensor type of blocker, basically. And this drug is called cinacalcet. What is it called? Cinacalcet. And basically what this is going to try to do is it's going to try to inhibit the parathyroid hormone production. If we decrease parathyroid hormone production, we should actually effectively help to lower the actual blood calcium levels. Sometimes this may not work though. And sometimes if the cinacalcet fails, you may have to go with what's called a parathyroidectomy as a result. Okay? So sometimes if the cinacalcet fails, this may lead to a parathyroidectomy. So we've already got treatment of hyperkalemia, hyperphosphatemia, hypocalcemia, but if they have hypocalcemia that over time leads to hyperparathyroidism, and then in severe CKD, hypercalcemia, we treat with cinacalcet or a parathyroidectomy. All right, so we said one of the actual ways that we're trying to reduce the complications of particularly CKD was a lot of the electrolyte balance and then the relationship of the secondary hyperparathyroidism. The other one is, again, continuing to reduce the complications, but this time it's with hormone imbalances, right? So we said one of the things that there was a decrease in EPO, right, whenever the kidneys are super damaged, and that is a reduction in red blood cells. What can I give them then that actually would try to undo this process if they're having severe anemia? Now, I guess that deserves the question though, right? What's actually a point at which I would need to do this? Generally, you're aiming for like a hemoglobin of anywhere from like 8 to 10. So I'd say once you start kind of getting less than 10, maybe, if a person has severe CKD, you can consider, but you're trying to kind of keep them within that goal of 8 to 10. And so sometimes you may need to give them synthetic erythropoietin, like Epogen, okay? Now, that's one way. The other thing is that we also said that whenever there is damage to the actual kidneys, there's a reduction in the GFR. That reduction in the GFR led to the kidneys making a lot of renin. The renin stimulates the renin-angiotensin-aldosterone ADH system, which causes a lot of effects on increasing your blood pressure, right? So there was the secondary effect of high blood pressure due to the chronic kidney disease, right? And this kind of goes back. One of the causes of CKD was hypertension. But then the complication of CKD is worsening secondary hypertension. I need drugs that are going to inhibit the renin-angiotensin-aldosterone system. We already talked about these. ACE inhibitors, ARBs, and potassium-sparing diuretics. To be able to, things that block aldosterone. These are the things that we're going to be treating in a patient with hypertension secondary to elevated renin levels related to a reduction in GFR. And again, aiming for a blood pressure goal of less than or equal to 130/80. Beautiful. Okay, the next particular thing. Again, we're trying to reduce complications, but we're trying to reduce complications associated with CKD, particularly of water balance. Now it's about water balance. Remember I told you that whenever the kidneys are damaged, they actually have the ability, they have this reduction in GFR. And so because of that reduction in GFR, they have a lot of water retention. And that water retention can lead to volume overload states, which can sometimes manifest through pulmonary edema, hypertension, peripheral edema. What kind of drugs would we give to be able to pull some of that actual water out of the body? That's where we can utilize things called diuretics. Okay, you can start off with things like loop diuretics and assess their response. And if you need a little bit of an extra pull, you can add on something like a thiazide diuretic. And if you need to pull off even more because they have other issues of heart failure, so on and so forth, you consider potassium-sparing diuretics. But what's another way? Water, sodium, and water restriction is another way that we can try to do this. Checking daily weights, trying to reduce the salt intake, trying to reduce your water intake. These are ways that we can try to reduce the complications associated with volume overload. Okay, the next one that I want us to talk about here is acidosis. You know, in patients who have acidosis related to severe chronic kidney disease. So reduce the complications associated with severe acidosis. So again, whenever there's severe chronic kidney disease, the ability to excrete protons decreases. So you retain protons and you reduce your bicarbonate reabsorption. So a lot of the bicarb gets peed out into the urine. This results in acidosis, okay? So this is called acidosis. Now, acidosis, whenever the pH is getting really bad, generally we may leave this alone, but if the pH starts getting less than like 7.2, generally, some books will even say less than 7.15. The basic thing is that the acidosis gets so bad that it actually starts causing effects on your cardiac system. You start developing decreased cardiac contractility. You start having a lot of electrolyte abnormalities and shifts. You start having resistance to vasopressors. These kinds of things warrants treatment with sodium bicarbonate. So this may lead to a sodium bicarbonate, maybe as a quick push or as an infusion in these kinds of scenarios, okay? Particularly in this state of uremic acidosis. All right, what else is another potential cause? Another potential complication associated with chronic kidney disease is albuminuria. So we have to reduce the complications associated with albuminuria. And we already talked about whenever that there's severe chronic kidney disease, your capillaries, glomerulus becomes leaky, it leaks tons of albumin in the urine, and that effectively leads to low albumin in the blood. And that will lead to third spacing of fluid. But you know what else? We also said that it actually can lead to a secondary effect, particularly causing an increase in lipid synthesis. But the other thing I want you to remember with a decrease in albumin is that we have to be able to protect against this proteinuria. And so whenever you have a lot of albumin in the urine, it's called proteinuria, we actually are going to utilize drugs. Their mechanism isn't completely known how the heck they do these, but ACE inhibitors and ARBs have been found to be effective in what's called proteinuria. So if you get a spot albumin creatinine ratio, or you check a 24-hour time of their albumin creatinine ratio, and you see that they're producing tons of protein in their urine, and they also have associated high blood pressure, it may be beneficial to put them on an ACE inhibitor or an ARB. Again, the complications associated with ACE inhibitors and ARBs that you use for blood pressure and proteinuria is that it can increase your potassium. It also may cause a slight bump in your creatinine as well. And so you have to be kind of aware of those things. The next thing that I want you guys to remember is that, again, you have to reduce the complications and CKD associated with high triglycerides and high LDLs. How do I remedy high triglycerides and high LDLs in response to a decrease in albumin triggering the liver to make tons of triglycerides, tons of LDL in response to really an increase in lipoproteins? I give them statins. So statins may be the best therapeutic regimen for these individuals. The other thing is it causes the platelet dysfunction, which can increase the risk of bleeding. How do I remedy that bleeding related to platelet dysfunction? You may need to give what's called DDAVP, which is called desmopressin, okay? And that may help to be able to activate these platelets and increase their activity, helping them to induce clots when you need them to, okay? But at the end of it all, sometimes all these measures fail. And sometimes as a patient's chronic kidney disease gets worse, so as the CKD worsens, or they develop any evidence of worsening acidosis, electrolyte abnormalities, intoxication due to drug accumulation, waste accumulation, volume overload, or uremia that is refractory to the medical therapies, or their actual GFR continues to reduce and reduce and reduce down to maybe even getting to like stage 4, stage 5, then at these stages you may have to progress to dialysis. And dialysis may just be a bridge to a kidney transplant, okay? And so there's different types of dialysis. We'll have a separate video on like hemodialysis and peritoneal dialysis and hemofiltration and renal transplants and stuff like that. But again, in CKD, if it continues to worsen, and what do I mean by that? They're refractory to medical therapies for the acidosis, electrolyte abnormalities, drug accumulation or intoxication of drugs, overload uremia, dialysis, or if their GFR is getting so low to the point where they are at stage 4, stage 5, and they're very anuric or severely oliguric and they're barely making any urine, you may have to progress to dialysis. All right, engineers, so that covers chronic kidney disease. I hope it made sense. I hope that you guys enjoyed it. And as always, engineers, until next time.